Well, good day. My name is John Marshall. I'm a professor of surgery and an intensivist at the University of Toronto, St. Michael's Hospital in Toronto, Canada. First, let me start by stating my disclosures. Probably the most important is the acknowledgement that the city I live in is on the traditional territory of a number of Indigenous nations, and we respect their history and their priorities. Commercial, I've been the chair of a Data Safety Monitoring Board, and I'm also the chair of the International Forum for Acute Care Trialists. So what I'm going to speak about in this talk today is the difference between frequentist and Bayesian approaches to integrating knowledge and to understanding information. This applies both to the generation of knowledge through research and to the application of that knowledge in clinical practice. What I'm talking about are not two different systems, but rather two different ways of looking at the world, looking at the same information. Starting with the frequentist approach, this goes back to the work of Bradford Hill in the late 1940s. He was the individual who introduced the randomized controlled trial that we currently use and rely on to draw valid inferences about information in clinical research. He was very much informed by the work of Ronald Fisher, who was a biostatistician from the early 20th century, who made multiple contributions to biostatistics, but importantly was really the father of frequentist statistics, and actually the person to be credited for or blamed for the arbitrary distinction that truth rests at a probability level of p less than 0.05. So here's an example of a frequentist approach to research. This was the ABLE trial that we undertook in Canada a few years ago. The question was, do patients do better when they are transfused with fresh blood? And so to study that question in a frequentist model, we had to make some certain assumptions at baseline. We assumed that there'd be a control mortality of 25%, that fresh blood could reduce that mortality by an absolute value of 5%, that we would look for an effect which was significant at an alpha level of 0.05 and with a power of 0.9. That then told us that we needed to study approximately 1,100 patients per arm. Assuming that some of these patients would be lost to follow-up, we ended up with a sample size of 2,510 patients. At the conclusion of that trial, you can see that we did not see a significant difference between standard blood and fresh blood. The p-value here was 0.38, and if anything, there was a suggestion that patients who were transfused with standard blood did better. But from a frequentist perspective, this is a negative trial that one really can't draw conclusions about, apart from the fact that there does not seem to be a difference in outcomes. Now, how is this expressed in probabilistic terms? The frequentist model of research that we are accustomed to using, the p-value actually reflects the probability of observing a result that is as or more extreme than that observed, assuming the treatment is ineffective. So in other words, we start from the assumption that there's going to be no difference, and we conduct the study, and the p-value says if we conducted that study multiple times, what is the probability that we would get a value that is the same or more extreme if the treatment is ineffective? If that's hurting your brain, it's not surprising. Frequentist statistics are based on the rejection of the null hypothesis. Now, there is an alternate approach, which is actually somewhat older in the statistical realm, originally attributed to Thomas Bayes, who was a British theologian from the 18th century. And I won't go into mathematical detail on the formula that you see here, but essentially what Bayes proposed was that the probability of an effect depends not only on what you observe, but what you expect to observe and what your prior assumptions are. And so the probability of the hypothesis is dependent in part on where you started off and not simply on what you see at the time that you conduct that research. So in Bayesian terms, one talks about looking at a posterior probability and a prior probability. And the posterior probability is actually a distribution of possible outcomes as the experiment proceeds. And so with a number of successes and a number of failures for a particular treatment, you generate a probability distribution. And the hypothesis in a Bayesian study is that the distribution of one drug is different from the distribution of the other, which was your prior probability at a certain level, often set slightly higher than a 95% level, but can be set really quite arbitrarily. So I want to just demonstrate this through the results of the corticosteroid domain of the REMAP-CAP trial that was reported this month in JAMA. This was looking at the efficacy of corticosteroids in the management of patients with severe COVID-19 infection. And what the study showed is that corticosteroids did somewhat better than conventional or usual care. So the probability of superiority was 93% for patients receiving a fixed dose of hydrocortisone and 80% for those patients who received shock-dependent hydrocortisone. The data are presented graphically on the left, and the lower the curve, the better the results. They're also shown as a heat map on the right, and again, you can see the distributions seem to be somewhat different. We're not making any assumptions here about a true or false conclusion. We're simply showing that there is variability between the results and describing the level at which that variability occurs. So in Bayesian thinking, the p-value or the posterior probability is the probability that the therapy is effective. There's no particular reason that has to be less than 0.05%. And clearly from a clinician's perspective, we don't necessarily apply such stringent requirements on our data. So let me just apply this in clinical practice. You're doing rounds one day and you're seeing a patient. You're told he has a temperature of 38.4 degrees, and the nurse asks you, do you want to start antibiotics? Well, obviously, you want to know what your prior assumptions are. If it was that this patient has been admitted from the emergency department, has a cough with purulent sputum, and is intubated with a pulse of 130 and a blood pressure of 90, you would probably say yes. On the other hand, if the patient was admitted from the OR and is 6 hours following a liver transplant, the answer to the question would probably be no. So the point here is that a decision and your interpretation of the data, in this case, the temperature, is critically dependent on the prior information that you bring to that interpretation. We make clinical decisions on the basis of prior knowledge and update those decisions as information accrues, and therefore we are Bayesians. And importantly, we don't say we have to be 95% certain. We say as long as we are on balance thinking that the benefit is going to be greater than the harm, we will make that decision. So this was looked at in the context of the Eolia study that evaluated extracorporeal membrane oxygenation for ARDS. The trial itself was a relatively small trial, just 250 patients. And as you see on the Kaplan-Meier curves, although the ECMO group seemed to do better, the result was not statistically significant at a p-value of 0.05. And so the conclusion here is that mortality was not significantly lower. As a clinician, however, that's not the conclusion you would draw. And you and Gallagher reanalyzed these data and showed that it's very much dependent on your prior assumptions. And if you have any sense that ECMO may be superior, which the bulk of the literature does show, the trial actually shows benefit for the use of ECMO in this population. So just to conclude, the implications here are that medical knowledge is not a non-changing body of facts, but rather a set of constantly changing probabilities. And informally, these probabilities are what make up our experience as clinicians. Formally, when you put them together as the results of research, they can generate guidelines. Both experience and guidelines, however, can be misleading when one attempts to apply them to the individual patient. Bayesian approaches more accurately reflect the uncertainty inherent in this decision-making process, and they are increasingly gaining popularity in the design of clinical trials. Thank you very much for your attention.